our next speaker is Bláthnaid Connolly. Where's Bláthnaid? Hi, Bláthnaid. So, Programme Manager, National Clinical Programme for Sepsis. And I think this is really interesting because I know there can... Oh, yes, sorry, I forgot to warn you. The steps are on this side. So now you have to walk the whole way across the stage. So she's going to take the clinical view here, and I know there can often be, you know, trade-offs and tensions between data collection and the clinical treatment. And Bláthnaid is going to talk about using data to improve clinical management of sepsis. So take us away there, Bláthnaid. Thank you.
Thank you, and thank you very much for inviting the programme to talk today.
Yeah.
Just before I move on to sepsis, the previous presentation, in my previous life as ops manager in the Mater and CHI and all the traumatic meetings I've had about, you know, performance and data, I'd actually go back to one of those meetings just to, if I had that dashboard available, just to be able to say, this is actually the truth. This is the performance, and we can talk about it for the rest of the morning, but this is the reality. And I think that's what's really important, is about knowing that you're speaking a truth. And it's a very challenging space to be in for people in operational data and all that, as we all know. So, okay, so I suppose Fiachra and Aoife asked me to come and speak around how we, as a clinical programme for sepsis, use data. And I don't have it's not going to be that easy, some of the slides. But I'll talk through them. So just to be conscious of that, that some of the information is challenging. Okay, so we couldn't talk about sepsis without recognising the tragedy that has come that we know about. Savita Halappanavar, obviously, without the tragedy of what happened to her and her family, we wouldn't have a clinical programme. So. And that often happens in the health services. We respond or we react. And we know that sometimes that makes us very sort of unhappy that that's what we do, and we're very forward thinking. But sometimes that is the reality of how we live and how we exist. So because of that, we now have a national clinical programme for sepsis and a national clinical guideline, which is based on international evidence. And that was first brought out in 2014. And a huge amount of work was spent implementing that clinically across all of our acute hospitals. And then without the families of, so this is Little Red here, his family are extremely, I mean, you know, they've done so much work, as have the Sepsis Foundation, and now the tragedy of Aoife Johnson's death really has brought home to us that sepsis is in our conscious awareness. I mean, it's just, we may struggle with it in terms of a concept and what it means and clinically, but we do know the words and we do recognise it. I think it would be very challenging for somebody to say that they don't. And I think we have to thank those families, because through their tragedy we know much more clinically. But so in 2019, the National Patient Safety Strategy came out, and within that, within the common causes of harm, the deteriorating patient, which is also something I work on, and sepsis are a key part of that in terms of how they are reduced and managed. So they're actually embedded within the strategy. And then from 2020 onwards, through HYPE data, we have a national sepsis report. And that's really gives us a sort of an information as to how patients are managed and clinically and what knowledge we have about them. And I'm going to talk a bit about the 2023 data, which we're just about to publish 24, but I'll give you some information around 2023. And then as a result of the real pushing of these families to increase awareness of sepsis, we have a sepsis public awareness campaign, which was started in 2024, about a year ago. We're still sort of running it. You'll see it in social media, and it's called Could This Be Sepsis? And it has had a huge impact for people in terms of the research that we did on it. So that's a real that's really significant, and you will still see it coming up on social media all the time. Okay, so this is the national data from the National Sepsis Report 2023. So what do we know, like, from HYPE? So we know that sepsis is extremely complex in terms of identification and treatment and management. We know that. Clinicians say that all the time. But we also know that it's quite difficult to code if they don't diagnose it. That's an absolute given, that the coding of sepsis is very challenging for coders, and we're very grateful to the work of the HPO in really working with us on trying to improve that. but we know that from 2023 there was 15,722 cases of sepsis, only in patients. We don't have any other data because it's hype-based, but that's underreported. So, you know, we can only go off what we have.
And sorry, Bláthnaid, why is it underreported?
Because of the difficulty in terms of clinically diagnosing it and naming sepsis as a condition. And any coders in the room will, I'm sure, support that. That basically the coding of it is very challenging, because the diagnosis of it is challenging, and you can only code it if it's called out. I can see a few nods in the room. So that's why we know, and also this is only inpatient data, Sarah, so we don't have all of the community stats at all because we don't have access to it. So we know from the data in 2023 that the detection rate is going up, but mortality rate is increasing, and that's a positive, definitely a positive sign. But probably the most important stats here from in terms of our knowledge of what's happening is the time critical element of sepsis. It's absolutely crucial that the patient, when it's picked up, is treated very quickly. So according to, in 2023, sepsis only accounted for 3% of all total inpatients, but 24.3% of total deaths. I mean, that's huge. If you just think about that statistic alone, that blows my mind every time I see it on a screen, and I've been looking at it for a while. And the reason is because that's telling us that these people are really sick. You know, they're really sick people, and as they move through their journey with sepsis, they're not necessarily improving, which is what we see in a lot of other patients, you know. And 72% of those patients are looked after on a general ward. So the sickest people are, because we don't have the critical care beds, but the patients with septic shock go to critical care and onwards. But if you look down here, the medical emergencies, the mortality rate for patients on the ward is 17% with sepsis. Other medical emergencies, so myocardial infarction, heart attack as we know it, is 4.8%, and ischemic stroke is 6.8%. So that's quite a big change, isn't it, in terms of, and really what we believe that to be connected to is, one, the complexity of how sick people get with sepsis, but also the pathway that they're on. What we know about stroke and MI is the pathway that those patients go on from when they hit the front door or from the ambulance. They start a pathway and they see it through. We don't really have that in the same way with sepsis, and that's really what we're working on. Only 16% of patients are surgical patients with sepsis, but they have a massive length of stay, 46.4 days. I mean, that's huge, isn't it, when you think about it in terms of capacity. Sepsis in children, so most patients with sepsis, inpatient sepsis, over 60% are older people above 75 years. That's the commonality. We hear about the tragedy, of course we do, but the reality is that it's an older person's illness.
And sorry, Bláthnaid, is that what kind of leads to the tragedies, that people keep an eye out for it more in older people? So then when someone apparently healthier and younger comes in, it doesn't trigger the same flags?
Potentially, yeah. I mean, I couldn't say yes or no to that question, but, it potentially, yes.
Yeah.
And there's loads of other reasons probably for it, but certainly in the cases that we do know of, the identification was very challenging. Okay, so and that's difficult. In children, we've counted in over years of cases and deaths, and that's because if we had it year by year, they'd be identifiable. So that's why we do it. So, and in pregnancy in 2023, there was only 260 cases across all of our maternity sites and non-maternity sites, but no deaths. So, so that's the data. That's what we have available to us, and it's really, really important. And we get that from HYPE. So, what are we doing with it? What are we doing with this information? What's the point in having it if we're not going to do something about it? And so, what we're looking at it is, how do we identify the clinical management of sepsis? So, we know this about these patients. What do we do? So, the guideline, we have a national clinical guideline. It was implemented, as I said, in 24, and we revised it in 2021. And that's really important because we're now revising it again, and I'll talk about that in a minute, because it is going to affect HPO personnel. We don't have a national guideline for children, but we do have international guidance that we have now implemented across all hospitals in 2022. So how do we make sure the clinical staff are aware and are up to date? And really what we do is we have HSE line training. We have 7 assistant directors of nursing, 1 in each used to be hospital group but now region, and they do a lot of education and training and audit. And we have a multitude of tools and resources available. We do a huge amount of promotion, particularly in September, which is Global Sepsis Awareness Week, month, day sort of thing. And there's a lot of information available to people. And then, of course, the public awareness campaign. That was driven by the public, that they wanted it. And we know that it has yielded very positive results in terms of that awareness. How do we look at the data to see what's happening for those patients? And that was where we were really challenged in the last year. Was that we knew that we had information come from hospitals through auditing, but we didn't have an overview of the patient journey and what happens to those patients when they go through those hospitals. Because the big picture is very big, but how do we know that the clinical management is really appropriately done in terms of the evidence? So what we've done in 2024, at the latter end, is we collaborated with the National Centre for Clinical Audit and the Healthcare Pricing Office, the HPO, to develop a national standardised tool. And it's an audit tool that we've put onto the MEG IT system. And what was really helpful in terms of standardising the data was that we created a script with the work of Jackie and her team. They provided a script for all of the coders and they randomised the data. So we couldn't have bias. As much as we could avoid it, we couldn't have bias. And I'm going to show you some of the results of that now, because that's the first time we know confidently that every person who went out and audited used the same tool, inputted it into the same system, and then I got the results, or the programme got the results. And we've just shared that data with every REO. We have it by RHA. And so they've received their own data in the last few weeks. So this is the national compliance. And I'm going to tell you what it is, really to show you that we are pulling out data. We are yielding stuff out of that clinical audit. But it's not, I mean, when you look at it, it's not telling us anything that the previous slide didn't tell us, except that the patients are mostly on the ward. They admit through ED. We sort of know that. The national compliance with the guideline is 62.9%. That's quite poor when the guideline's been in place for 10 years, 11 years. And most patients go home at the end of 30 days. So that's good news in a way. But it's not really telling us about those patients. But the next slide is. And we've sent this on to every REO for their own region. And we've sent them a national overview because they all asked, could they have a comparator? So what this tells us, and if I put this back up in the corner about the time critical piece. So what the audits are telling us, and it's really about 10 charts per hospital, so it's quite small, but it's consistent in what it's telling us, that the screening at the front door is happening very quickly. 87% of patients were screened appropriately and immediate action was taken when they were screened for potential sepsis. Then the form that we've spent years writing, building, designing, trying to get people to use, no one uses it. I can tell you that now, no one uses it. They don't even know where it is. Like I've asked people and they're like, we have a form? And you're like, oh my God. But the sepsis form is really important because it tells them what to do. And that's where the time critical piece comes in. So 17% of use, that's the national. So imagine that's an average. That's not good. Now, so if the form is never looked at, the screening and the risk immediately takes place. In other words, the clinicians are looking and saying, yes, I've identified why there's potential sepsis with this patient. Then the journey for the patient starts. Have they taken bloods, lactates, urine measurement? Yeah, 75%, that's pretty good. Have they given what they're supposed to give? Antibiotics, I'm going to get caught here because I can never remember them, fluids and oxygen if appropriate. Yeah, that's really good, isn't it, nationally? But did they do it in the time they were supposed to do it? No. 30%. And that's where the time critical piece comes in. We have a bundle clinically for a reason because we need it to be done quickly. And that's where we're working on. No, go ahead.
Sorry to cut across your Bláthnaid. So I'm looking at the 87% there, the screening and the risk identification. So is the form needed if they're getting from step 1 to 3 without the form?
That's a really good question. I've never been asked it.
That's why I'm here.
I've never been asked that question.
Okay.
I don't know how many clinicians are in the room, but we can ask about that. Now, what I would argue is that something is needed to tell them what to do quickly. Because what happens is...
Is that leading into the 30% that it wasn't done on time?
Yes.
That's the outcome?
Yeah.
Okay.
And this also brings us back to the diagnosis piece. If you don't use a form, when the hype coders are going to code the chart, how do they know for definite that that patient had sepsis? Because it's not documented
So that's
anywhere.
why you need the form as well.
Whereas the form is saying, is this sepsis? Yes, no, do this, 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 and this.
Yeah.
Okay. The problem with the form is it's really busy. Like, I wouldn't even put it up on the screen. There's a lot of information in it. I used to work at the front door. It's very difficult.
So can we redesign the form?
That's what's happening. You're ruining my presentation,
Sorry,
Sarah.
Bláthnaid, sorry.
Literally ruining it. Okay. So what are we doing now to improve clinical management? So the first thing we're doing is we're updating the guideline. And what we're doing is we're doing that now because things have changed a bit internationally. And that will improve patient outcomes. We're not going to expect people to give antibiotics for everyone within a certain period of time in terms of the sepsis 6. So that's really important. We're developing key performance indicators in terms of, for the hospitals themselves, in terms of reporting about training, about audit, about quality improvement. And that's been handed back to them away from the programme. But we will work with them on that. And they're under development at the moment. National HR, and this has come from the CEO, training is going to be made mandatory for all relevant staff across the HSC in sepsis. And that's the HSC LAM training. So we're updating that at the moment. That's going to happen this year, hopefully. And we've revised the form. We have a working group of frontline clinicians, really engaged, student nurses to NCHDs to consultants across the board. And we now have a revised form which is currently being piloted for 2 weeks across, it's about 11 sites. And you are going to, I know that the team were talking to the HPO in the last week or so to explain about it. So you are going to see the new form coming through. And the form is very different. And it's very, to me, it's still a lot of questions, but the clinicians like it. So we're interested to see what that happens. One, do people like it, what the feedback is? But two, will they start using it? Mm-hmm. Do you know, next year when we audit, is that statistic going to be better? And we've developed an action on sepsis 5-year strategy with our patient partners. And if we get that over the line and get that funded and implemented, that really spreads us across in terms of how patients and families are impacted. And the last thing is we're looking at, could we move from the national report to a national sepsis audit, similar to the ICU audit and trauma audits, and we're doing a feasibility. There's nothing, that we don't have that internationally, so we're looking at whether we could do it here. And then we're expanding the MEG tool to incorporate all of the early warning systems, EMUs, INUs, etc. And that's it.
Okay, thanks. Amazing.
Thank you,
Thank you. And I guess the real lesson is there, like, this is why the data is needed. Like, there was a question earlier, does this actually improve patient outcomes? And that's the answer, yes. Okay. Well, look, take your seat. Oh, did anybody have a quick question for Bláthnaid? We're kind of running behind on time, but if anyone has a quick one. No, okay, so take your... Oh, there was one, sorry.
Hi, sorry, it's more of an observation really than a question, I suppose. I work in a hype office.
I can't see you, sorry.
I'm here.
Stand up.
Thank you, sorry, I couldn't see where you're coming from, sorry.
I suppose from a hype coding point of view, we had a very dynamic clinical nurse specialist in our hospital. So her position was moved on, she's moved to a different post. So now we don't have her. I can tell you, we never missed a sepsis diagnosis when we had her because she was on it and she was after, every form was filled, and it's a huge loss. So unless a hospital has that resource, I think, the hype coding will never be, 100% accurate for sepsis.
Right, so there's institutional kind of knowledge there that needs to be
yeah.
kept. Okay.
I think to answer that question, I think that's a really important point, that human interaction of education training is absolutely fundamental. But there is another part of it, which is why we have to ask ourselves why there's almost a fear of documenting sepsis and what the end result of that is, because we know that exists. Anecdotally, we're told it all the time. So we do have to question that. It's very complex, it's very difficult, and it's not completely avoidable. We know those facts, but we could improve the recognition and the treatment, but that takes a lot of work. And I think that's what that clinical nurse specialist was doing, obviously very well, and it had that downstream impact on yourselves. But we need to broaden that, because we have 15,000 cases every year, and probably more.
Okay, thank you, Bláthnaid.
Okay.